Thank you again so much for being here today. I'm really excited about this program, which is entitled Diverse Cultural Perspectives in End-of-Life Care. This is going to be presented by some of our clinical staff here at Hospice and Community Care, as well as some staff from our sister organization, Hospice of Central PA. So I am just going to take a moment and introduce the staff that will be speaking today, if you wouldn't mind to stand. We have Arielle Miller. Arielle is an LPN and our IT trainer, and she's going to moderate for us today. We have Elissa Dougherty. She's an RN with Hospice and Community Care. We have Jessica Markulik. She is an RN and the Choices Palliative Nurse Coordinator. Thank you, Jessica. Darlette Norfleet. She's an RN and the Director of Education and Staff Development at Hospice of Central PA. And Pilarte. Anne's a social worker for our Sunflower Pediatric program. Also joining us today, and she is just taking a quick break, but she'll be up here in a moment, is Erin Lehman. She's a social worker with Hospice and Community Care. So without further ado, I will turn the program over to Arielle. Thank you.
All right, good afternoon. As Amy said, my name is Arielle Miller. I'm the IT trainer at Hospice and Community Care, but I started 4 years ago as a nurse. And I just want to say thank you so much for inviting us to be here today. I know we're really excited that you asked us to come. So, at the end of life, we are tasked to create spaces for all people to feel seen, understood, respected, and valued. One way that we can do this is by recognizing the cultural diversity in our community that encompasses all of the differences that we have. Those differences are things like our race, ethnicity, religion, sexual orientation, age, mental capacity, economic status, geography. That's just to name a few. All of those differences intersect and shape our individual identity and our experience in the world. As an organization, we recognize that these differences can create barriers to seeking or accessing care. We're working really hard to break down those walls by equipping our staff with meaningful and equitable care. Some of the things that we've currently been able to do are providing our staff with rich opportunities for education about cultural diversity, having access to online interpretation for a multitude of languages. This year we've created and implemented in-person interpretation for Spanish-speaking patients. We assist patients and families who are struggling financially, and we do so much more. In addition to what we do for our staff, we also try to be present at community events. So those are things like Pride and a Latino Health Summit, and just any other various events or festivals that are geared toward marginalized or minority communities. As we work to serve patients and families and caregivers from all walks of life, we desire to go above just treating their symptoms and managing their medical treatment. We want to care for our patients as the humans that they are. We want to honor their rich history, their unique sets of values, and their ideas of what end of life looks like. You may be wondering why this is important now. Well, as we become more aware of the inequities that exist in the world around us, especially in healthcare, we also are acutely aware of the fact that our patients, our community, have been subject to medical mistreatment or harm, discrimination, or have otherwise had their trust in healthcare broken. Because of this, we want to do our part to prioritize serving each individual patient, family member, and caregiver in a way that's personalized, accessible, safe, and compassionate. One way we can do this is to embrace the diverse identities and backgrounds of each person that we encounter. Today, you'll get to hear about a few of the different populations we're privileged to care for. And first up is Elissa Dougherty to share with us on caring for individuals with intellectual disabilities.
Thanks so much, Arielle. So today I'd like to tell you a little bit about a patient who I'm going to call Crystal. She's an amalgamation of several patients that we've had the pleasure of caring for over the past few years, and she's going to help highlight some of the joys and some of the challenges that we've faced when it comes to caring for individuals with disabilities, specifically intellectual disabilities. Crystal is a middle-aged woman who lives in a community-based group home and has done so for about the past 10 years. She loves having her own room, planning out her day, and participating in the activities that make her happy. She sees her sister at least every week, and she shared that she loves having her independence. Her roommates have lived there for about 15 to 20 years as well, and they have similar abilities to Crystal. Last year, she started to experience some pain in her belly and bloating and some other symptoms that were a little bit confusing to her. She couldn't quite put her finger on what they were. They were really difficult for her to convey to her caregivers and her family. And through a lot of somewhat frustrating and really uncomfortable doctor's visits, she was eventually able to come to a diagnosis of ovarian cancer. Crystal's family opted not to share this diagnosis with her. Their fear was that if she hears she has cancer, she's gonna give up. She thinks cancer means she's going to die. She's not gonna die, we're gonna fix this. They didn't explain to her that she was going to go through chemotherapy and radiation treatments, what they entailed, or any part of the course of care to her. She had no say in what was going on in her own body. This caused a lot more confusion and discomfort for Crystal. Not only was she uncomfortable, but now she was sometimes sick, she was more tired, and she just felt terrible. Often individuals, especially in group homes, individuals with intellectual disabilities don't get to participate in any type of care planning, even in a way that would be appropriate for their intellectual abilities. They don't get a chance to say, this is what I want to do. It's not really a challenge that we see with the community at large. We all get to determine our care, or we at least have a voice in what we want to do with our bodies. In the case of individuals specifically in group homes, physicians must act in the interest of preserving life at all costs. Physicians, caregivers, and families often lack the training and time that it takes to appropriately describe a disease process or treatments in a manner that are actually going to be understood by the individuals with potentially altered or limited health literacy. As our story progressed, Crystal's cancer progressed, and it was found that additional rounds of treatment were no longer going to benefit her. Her family, because of these regs, could not be the ones who said, enough is enough, we want to stop. Crystal couldn't be the one who said, I don't know what this is and I'm done with it, I don't want to keep feeling this way. State regs said that 2 physicians had to agree that Crystal's condition was terminal and that she had a 6-month prognosis. Then they could decide to introduce palliative care, and then they could finally introduce hospice care. Luckily for everybody involved, Crystal's family and the group home were actually familiar with hospice and community care through prior contacts for both their family and other folks that we've helped care for among that group home's other residences. One of the things that sets us apart is that we're really familiar with the stringent regulations that group homes have that are very different from skilled nursing facilities. Group homes are often staffed by non-medical individuals, and they have a whole host of regulations that are really geared towards always getting their residents better and keeping them better. Hospice services really provide this bridge of understanding kind of how to interpret end of life, how to manage those symptoms, and really how to demystify the unknown for these folks. We also provide supports beyond just the medical. Support for Crystal went beyond nursing and personal care and those physical supports, and included social work, chaplaincy, volunteer services, and bereavement support. Not just for Crystal and her family, but the staff who worked with her and knew her so well, and the folks that she lived with, because that's a huge bond. We provided not only anticipatory grief services, but also in-home services after Crystal's death. One of the things that was really poignant is that at one point, Crystal asked her social worker, okay, I live in a group home. I have a bedroom here. So when I get to the funeral home, will I have a bedroom there? So it kind of brings home why we need to have those people who can bridge between hospice and the rest of their lives. As Crystal's disease progressed, she came closer to end of life. We were there to help her caregivers work through her symptom management, because even in a regular home, our symptom management can feel a little complex. Those of you who have gone through this know that it can feel overwhelming. Layer on regulations, it can be even more challenging. So we're here to help walk through what each piece of symptom management might mean to those folks. We provided care for Crystal as well as her roommates, caregivers, and her family. We supported her roommates through their questions and worries as they saw her getting sicker and more tired, as she spent less time with them and more time in her room. And with Crystal's sister's permission and the help of the facility staff, their roommates were actually able to say goodbye to her at the time of Crystal's death. Bereavement services through our Pathways Center also provided in-person services at the time of death and afterwards. And I just wanted to thank everybody here for kind of taking a few minutes to listen to me as we talk about how we work together with this community, because it's growing and it's just going to keep growing as the cute little kids we see grow into adults, and as those adults whose parents can no longer care for them at home age and die, and we need to plan for them. I think hospice is doing a great job of thinking forward to how we can continue to network with these facilities and maybe get some more advanced care planning in place, we hope. So I'm gonna turn things over to Erin, who's gonna talk to you about the Amish community.
My name's Erin. I'm a social worker at Hospice. Up until very recently, I worked with the Purple Team, which is southeastern Lancaster County. I would say on any given day, about half of my caseload was Amish folks. Recently switched over to PRN, which just means that I'm working very part-time. And the reason for that is that I had the opportunity to take on a role as a caregiver in the Amish community. And so I'm splitting my time between the two things. And disclaimer, I'm not Amish. You may be shocked to know that, but hopefully I can speak to the community, shine a light kind of on their needs and what makes them beautiful, because they really are. This will be fast. I could teach a whole class on this, so I'm just gonna run through really quickly. In Lancaster, Chester, and York counties right now, there are about 45,000 Amish folks. That number is growing exponentially. I think something like 50 to 60% of that number is children under the age of 18. So they're not going anywhere. They're gonna continue to grow, and I have seen hospice and community care take note of that and really start to think about how we can better service community. As word spreads among their community that we are serving them and serving them well, we're gonna see more and more folks come in. So that 45,000 number is split into church districts, and those are local districts. There's about 100 to 200 folks in every district. More than half of those are under 18, usually. And the church really is kind of the locus of decision making. I think, when we think of the Amish community in general, we think of them sort of being ruled by the church community, and in a lot of ways they are. Medical decisions, though, are up to the household. Those are family decisions. So when to call hospice, what kind of care their loved ones receive, who's providing that care, those are family decisions. For the most part, the church can and will get involved, and I've seen it happen. As a social worker, sometimes there are cases where we are needing to work with the local church, the leadership. And I'll just give you a quick example. I will call him Amos. That is not his name, but he was one of my patients, came onto hospice care at the recommendation of his physician. 7 children, so 7 in-laws, many grandchildren, many great-grandchildren, and a spouse who was still involved. And they simply could not agree on a course of care for Amos, meaning, half of them thought hospice was appropriate, half did not. Some thought skilled nursing, and we really just couldn't come to a decision. I'm a good social worker, but I wasn't that good. So we had to get the church involved, and what that looks like is, a support. The church will form a support group for the family, and sometimes as social workers and staff will end up working then with that support group, just as an added layer of input, which I think is a really special thing about that community. They have tons of resources within their church districts. Let me just talk about 2 of the ways that I think hospice and community care does this really well. And I've seen it happen again and again. The first is our fee reduction program. My Amish patients, with a few rare exceptions, do not have insurance, do not have Medicaid, do not have Medicare. All of the care that they receive is out of pocket. And for some that is not an issue, for many it is an issue. And hospice and the fee reduction program works beautifully within that community to make sure that they get the services they deserve. And it's such a good resource, and as I see the word spreading in the community, I think we're gonna have more and more folks come on, so hospice, buckle up, they're coming. And then the other thing that is just my favorite part is the home hospice dedication to keeping people at home through end of life as much as is possible. This Amish community is so focused on family and home and roots and steadfastness, and the idea that we can help them to avoid hospitalizations, unnecessary separation from families, grandchildren, great-grandchildren, is probably their favorite thing about hospice from what I have heard, and that I can't overstate that they have our phone number, they know they always have our services at hand, but they can keep their loved one at home, surrounded by their family and their church. That is so important to them. And I think it's a beautiful thing that our staff honors that really, really well. I'll just say, my Amish friends, they have a really strong belief in divine providence, in patience and humility. You will hear time and time again, I don't know if y'all have heard it, that they will say, I'm trying to be patient. I'm frustrated with this illness, but I'm trying to be patient. I'm ready to go home to Jesus, but I'm trying to be patient. And that, when we can come in alongside them and just walk through them for as long as it takes, it's so special. It's such a gift. That yielding to God and to community that they have, it makes for really rich, deep, long-standing relationships, complex in the best way. And our hospice staff comes in with humility, with communication, compassion, and it gives us a really good context in that community when they see that happening, because they know that we're gonna come alongside, we're not taking charge, we're gonna come alongside and let them be who they are and just love their loved ones right up through the end. Having that support in the hardest time of your life means the world to them, and it would to me too. So I'm grateful to be a part of it. Thank you for your support. I'll just say, as a social worker, I know how much your support means to hospice and community care. I see it used every single day, and I'm very grateful, so thank you. Oh, and this is Jess Markulik.
Hi everyone, my name is Jessica. I'm an RN. I am the coordinator for the Choices Palliative Care Program through Hospice and Community Care. But prior to that, I was an RN case manager for a long time. Most of that time I spent on the Orange team, which is where most of our Latina patients tend to live in Lancaster County. I am also Latina and I'm also bilingual. So through my years as a hospice nurse and also in trying to navigate end-of-life care within my own family, I've come to notice that there is a stark difference in how hospice and palliative care is accepted or sometimes not accepted in the Latina community as compared to the mainstream American community or culture. Hospice and palliative care is not very widely understood or accepted in Latin America. There's numerous myths and misinformation surrounding it. The idea of hospice and palliative care is a very new concept in Latin America. And I feel like it's important to mention that the Latina community comes from various different countries, various different backgrounds. It is not a monolith. But that being said, there are some key similarities and concepts central to Latina culture and beliefs that do make accessing end-of-life care challenging. For example, Latinas will hold fast to the concept of fatalism. What will be, will be. Latinas tend to live in the present, not in the future, so trying to plan ahead can be challenging. Often I hear patients say things like, well, when it's my time, it's my time. So we have a difficult time, I guess, visualizing some of and making some of these goals of care decisions because of that. Religion can also be very important to Latina families, so often they will view accepting hospice care as giving up. Another statement that I have heard a lot from my patients is something like, well, I am leaving this in God's hands. I don't want to plan or look ahead to how my illness will change because I'm holding on to my faith and I'm leaving it and I'm trusting God. Often a Latina patient and family will refuse hospice care the first time it's offered simply because of a misunderstanding. They didn't understand what that is, what hospice is, or what palliative care is. Language barriers may exist for Latina families when they meet with their healthcare team, even when an interpretation system is used. This is due to the fact that in addition to language barriers, again, there's some key aspects of Latino culture that are at play. It is considered rude to ask questions of authoritative figures. So doctors, nurses, social workers, they are all considered authoritative figures in the Latino community. So oftentimes if we as healthcare providers are having conversations with our Latina patients and we're asking, do you have any questions? They will say no, even though they actually do, but they just don't want to be rude to us. Another thing to keep in mind is that elderly Latinos will often defer their decision-making to their adult children. Taking over decision-making is a way that we feel we are caring for our parents. Our elderly Latina family members feel like it is their children's duty to take over decision-making, even if they are still cognitive and able to make these decisions themselves. So the assumption that a lot of healthcare workers have is that the patient wants to be the driver of their care, the patient wants to maintain independence, and oftentimes that is not the case with a Latina patient. So as these needs became more and more apparent to some of the bicultural staff here at Hospice and Community Care, a committee was formed in order to bridge the gap. We call it the Latino Resource Team, and it has been active since 2011. And it's comprised of staff members from different departments within the Hospice and Community Care organization. We volunteer our time in order to improve access to hospice care within the Latina community. The Latino Resource Team has been instrumental in ensuring that HCC has educational materials in Spanish, offering continuing education to the community and also to staff, and just offering that support to our non-Latina colleagues as they're caring for this community. Recently, we spearheaded the implementation of a new project called the Interpretation Support Team. It is a small team. Presently, it's just myself and one other member, but it is comprised of staff that are bilingual and bicultural, and we are available to help our colleagues by making phone calls, maybe helping them plan for a visit when they know that they're going to be meeting with a Latina family and they know they're going to be discussing sensitive topics. We make ourselves available to go out and make a joint visit with them to help with that in-person interpretation. It's not just about the language barrier. We can also serve as a patient advocate, as a cultural broker, helping our non-Latina colleagues understand some of these nuances and differences. And like I said, we're a very small team, but we do hope to continue to grow in the future because there is certainly a great need. So I will leave you with a success story of this new team. Recently, we had a patient on the Choices Palliative team, and again, not his real name, but we'll call him Mario. He was a Latina gentleman with congestive heart failure. He lives with his wife in subsidized housing in Lancaster City. They have 2 daughters and they live in Lettitz. The daughters are very involved and they help bring them groceries and pick up their prescriptions, but they work during the day, so the daughters are not always there for his doctor's appointments. Mario and his wife are both not English proficient, and so they inquire an interpreter for all of their healthcare visits. I accompanied the Choices provider, the nurse practitioner, on her first visit to introduce him to the Choices program and introduce herself as well. This became a very lengthy visit. He and his wife had multiple questions about his condition, about congestive heart failure. It just became apparent to us that this is an illness that he has had for several years, but he has never understood it, even though he's had an interpreter at every one of his doctor's visits. So we really took our time to try and answer all of their questions, and that really helped us build a rapport with him and his wife. We just realized that he just never felt comfortable asking these questions. At the end, they were very grateful for myself having the ability to do this in-person interpretation for them, as well as just to be able to understand where they're coming from, why they've had all these unanswered questions for years. And just recently, our nurse practitioner went back to do a follow-up visit, and I actually didn't go with her. She was able to use the contracted interpretation system that we have, and it worked out well, where it had not worked for him in the past. Now that he had that rapport with her, he felt comfortable to ask the questions or ask for clarifying information through the interpreter. So that, again, that's one of the things that we're hoping to continue to work on as we move forward. Thank you all for your time. I will pass it on to Darlette.
Thank you. Hello. My name is Darlette Norfleet. I am not a public speaker. I am an educator, but hang in there with me. So I was tasked to talk to you today about another underserved population, and that's the Black African American population. But I want to start with some statistics to give you some perspective. So in 2023, collectively, HCC and HCP cared for 4,882 patients in hospice. 161 of those patients were African American or Black. That means we cared for 3.3% of patients that were African American. In our bereavement program, collectively, HCC and HCP cared for 10,872 patients Of those patients, 24 were African American or Black. That's 0.2% of the patients we care for, or families we care for. In community bereavement, we served collectively between HCC and HCP 1,595 families. Of that, 11 families were African American or Black. That is 0.7% of the total population we care for. So you see, there is a huge disparity in this population of people. But I think there are 4 reasons, and there are many reasons, but I'm gonna give you 4 that I think are huge and areas that we can really make a difference in. The 4 areas are access, accountability, understanding, and trust. So we'll start with access. We have to make ourselves more visible in the African American and Black community at clinics, hospitals, schools, doctor's offices, so that this population knows we're available. Let's talk about affordability. There is a lot of people of color that have no idea they can afford hospice services. What we have to do is make sure they understand that insurances like Aetna, Health America, Highmark, Medicaid covers hospice as the hospice Medicare does at almost 100%. And that, let's not leave out our uninsured and underinsured. There are options for them, and that's where all of you come in. So the next thing I want to talk about is understanding. That's a huge component. We have to help our African American and Black community understand that while hospice takes care of patients at end of life, it's not about the dying, it's about the living and capitalizing on whatever time you have left. And it's also making sure they understand that there's support for their family, support and guidance. Does that make sense to you? The final thing is trust. And so you might ask, why does trust matter? Well, to be very honest with you, in history, there have been times where African Americans and Black people have been minimized and devalued. And so I'm going to share with you just a couple of things that makes us feel this way as a people. If you've ever heard of Tuskegee syphilis experiment, where Black people were used as, they were used and not given the treatments that were available because the medical society wanted to see how the disease would progress if it was untreated. And that was without their consent. Another example is there are a lot of African countries where those people are used as for clinical trials without their consent. And then I'll share one more with you. Have you ever heard of Henrietta Lack? Her cells were used, unbeknownst to her, they were retrieved in 1951 and used for polio vaccine. It was used for gene mapping. It was researched in cancer, and she was never aware that her cells had been taken and used in this way. So you see why there's a lot of mistrust? So when doctor's offices say, I'd like to refer you to hospice, there's a lot of Black people and African Americans that go, no, you're not, right? Because they think you're giving up on them. So we've got to work at building some trust in these communities. So before I leave you today, I want to share a story. I cared for Mr. Williams long time ago. That's what I'm saying. And this was an African American man. When I got to his house and opened the door, he looked at me and he goes, they sent me a sister. And I said, yes, why did you say that? He goes, I don't know, I was worried. Now, I didn't ask him what that meant, but I knew what that meant. But despite his trepidation, he gave me an opportunity to care for him. So I'd go see him, and his granddaughter would be there. She was around 3, and she loved her papa, and she loved my stethoscope. So she listened to his heart, listened to my heart, And then one day I showed up with a toy stethoscope. And so she listened to my heart with it and listened to his. But she was there a few months later when he died. And I was on one side and his wife was on the other, able to honor him at end of life. But what makes the story even more special is a few weeks ago, one of the social workers came in and said, "Do you remember caring for Mr. Williams?" I'm like, "Yeah." She goes, "We just picked up his daughter's mother-in-law, and she wanted me to thank you. Thank you for honoring him and caring for him. And she also wanted me to tell you that his granddaughter is now in nursing school to become a nurse." So that was wonderful, it warmed my heart. So before I go, I just want to say thank you. Thank you for supporting us so we can support others. Thanks. And I'll give it over to Ann.
And Darlette, if you are not a public speaker, I don't know who is. Hard act to follow. Hello, my name is Ann Pilarte. I am a social worker on our Sunflower Pediatric, Palliative, and Hospice team, as well as the co-chair for our LGBTQ+ resource team. The LGBTQ+ resource team is a group of hospice and community care staff members who support the advocacy and care of our patients, families, and staff members who are part of the LGBTQ+ community. Individuals in this community identify as lesbian, gay, bisexual, transgender, queer, and many other gender identities and sexual orientations, hence the plus. Unfortunately, it's very common for individuals in this community to have health disparities and barriers to optimal health care. Studies have shown that members of this community are more likely to delay or not seek medical attention, are more likely to receive medical care in the emergency room setting, and are less likely to have health insurance compared to the cultural majority. People in this community are also less likely to have traditional familial support systems such as adult children or a spouse to support them in their care. Seeking and receiving excellent end-of-life care for folks in this community can be especially daunting based on the combination of health disparities, barriers, and lack of support. Some of these include what's called anticipating discrimination. So if individuals have experienced discrimination within the healthcare system in the past, it's very likely that they will anticipate more of the same with end-of-life care and therefore delay seeking hospice care. So if every time I go to the doctor, I feel uncomfortable, I feel judged, maybe I'm not gonna go back to the doctor anymore, and this idea of taking care of my end of life isn't something that I'm really excited about either. There's also that support network. Because patients who identify as LGBTQ+ are less likely to have traditional familial support such as a spouse or an adult child, there is concern among them that they may need to depend on a facility or paid caregivers to take care of them in that most vulnerable stage of their life at end of life. Or that their main support givers will be overlooked for support needs. For example, if someone's life partner of 30 years is not acknowledged as family, they may not receive support during the patient's care or for bereavement support, and that's worrisome. There's also something called intersectionality, or the overlapping and interconnected layers of social categories. So individuals in the LGBTQ+ community are also parts of lots of other different types of racial, economic, or cultural groups. And the combination of the different stressors of being associated with those marginalized groups is just exacerbated. So people of color who are in the LGBTQ+ community or have intellectual disabilities or live in poverty, it's just layers upon layers of discrimination and barriers that they're facing. There's also the complexity of religion and LGBTQ at end-of-life care. Hospice care includes supporting our patients' spiritual well-being. And for many individuals in this community, there's a personal history of tension or trauma or rejection within their religion that can become a barrier for a peaceful end-of-life experience. So how does hospice and community care try to mitigate these barriers? We provide training during orientation to highlight the barriers faced by this community and ways to build trust and rapport. Simple ways we build trust and rapport include allowing the patient to choose their primary caregiver or the person that is going to provide the most care for them. And we ask them, who do you consider family? Who's in your support circle? And we also ask, what do you prefer to be called? We want to know who they are. How do they identify themselves? And we respect what they ask us to call them. We support ongoing educational opportunities to keep our staff up to date on optimal ways to care for this community. Hospice and community care was recently able to support the hope and wish of one of our patients, which was to marry his husband before he passed. His hospice team shared his joy and honored the celebration with a gift of flowers. Our sunflower team had a young trans man who had a lifetime of medical needs and complexities. So he had a lot of experience in the healthcare system. And he voiced just how happily surprised he was by the genuine care and commitment our team had to him and his family. And finally, I wear a rainbow sticker on my name badge as a symbol of my support and advocacy for this population. And I remember a caregiver telling me, "Oh, I like your rainbow sticker. We're a rainbow family too, you know." And it was just a simple but important exchange that helped build trust and let that caregiver know that she and the patient were receiving support from an agency that sought to provide them with optimal care. Thank you so much.
All right, well, thank you guys so much for listening. As you heard from our truly incredible presenters, we've had some really, really awesome successes in caring for patients from these diverse backgrounds. With that being said, we do still have work to do to ensure that every person in our service area can have access to this awesome care. Serving all people in our community is a very integral part of our mission, vision, and values at Hospice and Community Care. And together, we're making strides in understanding and meeting the unique needs of those we serve. But we have to keep growing and pushing forward and learning. And I really appreciate that you all wanted to learn too. One of the things that originally brought me here to hospice, and one of the things that keeps me here, is patient-driven care. I came to hospice in 2020 during the height of COVID, and let me tell you, patients did not have a say in their care. No matter what their background was, we were calling the shots. And hospice offered me a very different experience. It offered me the ability to see what it looked like when we meet the patients where they are and honor them and walk alongside them through one of the most difficult times of their lives. So with that, I'm going to close with the following. At the end of life, we've been given the very sacred responsibility to care for the patient and honor the life they've led. By committing to serve all people from all walks of life as an organization, we uphold the dignity and humanity of each person we serve. We honor the legacy of Dame Cicely Saunders, the founder of modern day hospice, who said, "You matter because you are you, and you matter to the end of your life." So thank you for listening, and at this point, we'll take any questions that you may have.
Elissa, your intellectual disabilities, does that include dementia?
So the question was, does intellectual disabilities include dementia?
In this particular instance, no, it does not include patients with dementia. However, we do have some fantastic resources for individuals with dementia, and we do have fantastic supports for individuals with dementia, actually kind of through all stages, because dementia doesn't have to be a primary reason to come on to care. We support folks in kind of all stages of dementia.
And do you recognize power of attorney?
The question was, do we recognize power of attorney? Yes, if someone is incapacitated and no longer able to make decisions for themselves in the dementia community, we absolutely can recognize power of attorney.
Any other questions? All right, well, with that, I will pass it back to Karen. Thank you again very much for listening to us.